Evening and welcome everyone. I'm Maria Morgan, President of the British Association for the Study of Community Dentistry, or BASCOD for short. I'd like to welcome you to the third session in our new series of masterclasses, which aim to offer mentorship and key insights into public health, dentistry and strategic health leadership from past presidents of BASCOD. I'd like to thank Eric Rooney, who was past president of our society between 2016 and 2017, for agreeing to share his career knowledge and experiences in his presentation entitled Public Health, What's in a Name? After all, that's the core business of BASCOD. Thank you, Eric. On our panel this evening, we also have Aisha Masood, our BASCOD Council Lead for Service Delivery. And to kick off proceedings, I would like to hand you over to Ross Keat, who has organised the sessions, our early stage career council member and specialty registrar in dental public health. Ross.
Good evening, everyone. I'd like to again thank Aisha for joining us this evening, and also Ilona Johnson, who's been helping us with the masterclass sessions to date. I mean, none of this could have been possible without the support of the panel members and yourself as well, Maria. So just a little bit of housekeeping before we get started. Please could everyone keep their microphones and cameras off for the duration of the presentation this evening. The video for this is going to be uploaded to the BASCOD YouTube after the event. So if you don't want to be made famous through that, then I advise you keep your video off for the duration. We're also going to circulate an evaluation form after the event to allow you to claim 1 hour's CPD for the session. So allow me to introduce our speaker this evening. So Eric qualified as a dentist in 1983 and has worked in clinical practice and also held a number of roles in the National Health Service, including clinical director, medical director and consultant in dental public health. He has a wide experience of dental policy development, and in 2008 and 2009, he co-authored NHS Dental Services in England, an independent review led by Professor Jimmy Steele. He was clinical lead for the Department of Health's subsequent dental contract reform programme. He was active in the BDA in his early career and served as chair of the NHS Policy Group, has been an invited board member of the Faculty of Dental Surgery at the Royal College of Surgeons of England, and is a past president of the British Association for Community Dentistry. He was Deputy Chief Dental Officer at NHS England from November 2015 until January 2021, where he led the work on developing local dental networks and integrating dentistry within the developing NHS. Latterly, he was engaged in the development of policy and protocols for dentistry during the COVID pandemic. So I'd like to pass you over to Eric, who's going to give this masterclass session this evening. Thank you.
Thank you very much for that introduction, Ross, and welcome everybody. It's a pleasure to be here and to be able to present this talk to you this evening. I think we've got a mixed audience in terms of people who are very well experienced in dental public health or community dentistry, and we've obviously as well got some younger people or people with less experience, and I guess this is predominantly aimed really at that audience. So forgive me, my more senior colleagues, much of this I'm sure you will be well aware of, and some of the things I'm going to say you will be doing all the time. But I want to try and encourage particularly our younger people, and definitely the people who are not consultants in dental public health or not people on the training pathway, to recognise that actually dental public health and community dentistry and all of the kind of things that we do are not the sole province of having that title of specialist or consultant. So I hope it will be of some interest, and look forward as well to the discussions at the end. So the aim really, a bit like the other two sessions that we've had already, is to just kind of reflect a little bit on my career and the kind of things that have happened and the opportunities that have presented themselves, and as a bit of a kind of a guide to help particularly, as I say, younger colleagues think about how they can develop their own career, how they can influence others if they are minded around prevention and around the ethos of public health, how they can help to encourage others in the teams that they work with to adopt a similar philosophy and to focus on some of the things which are not just the pure clinical dentistry that obviously, if we're dentists or therapists or hygienists or whatever, dental nurses, that's where we start. We start in that surgery in a very clinical and individual focused way. And I guess what I hope to try and do is encourage you to think about then broadening out or taking opportunities to broaden out towards a more public health perspective. So what's in a name? A little bit of kind of the standard background, if you like. Dental public health, we generally consider it to be these three things in the circles at the centre. Obviously, health improvement, which we all know about, health protection, which we've been very much exposed to in the last year and a half or so, and healthcare public health, which I think probably, if I was to look at the balance in terms of these three circles, although I've got them overlapping there, and I think that's really important, the balance for me probably rests very much towards the healthcare public health aspect that sits at the bottom there. And I put it at the bottom when I drew this because I think, and Ross and I were having a bit of a pre-event chat the other day and just discussing this, and it made me think. I think healthcare public health in a way kind of pervades the other two to an extent, because without that element of engagement with the rest of healthcare, with the understanding of how the healthcare system works, then actually one can have all the ideas in the world about health improvement and good things to do, or even health protection things that would be really important. But unless we understand the landscape within which they exist and some of the politics that pervades that landscape, then actually it's sometimes very difficult to make things happen or to achieve what are very, very laudable aspirations. The other couple of things, titles, if you like, that are on this slide are what's in a name, of course, and BASCOD up there, although I'm talking predominantly, I guess, about dental public health, and Maria's mentioned that at the beginning. Actually, BASCOD stands for the British Association for the Study of Community Dentistry. So it's a slightly broader approach in BASCOD that we take, and we encourage a much broader kind of input from both dental professionals and professionals outside of dentistry who have an interest. And the other thing that, of course, all of dentistry is generally considered to be, and public health to an extent, is an art and a science. Clearly, traditionally, the art of making lovely looking dentures that are almost imperceptible from natural teeth and all that sort of thing, and lovely sculpted fillings, all the things we got taught when we were younger. And then, of course, the science that underpins that. But I think that art and science isn't just the purview, if you like, of the clinical specialties. Actually, there's a lot of science for sure, and underneath I've got their intelligence and research and whatever that underpins our activities. But there's also an art to this, but it's a different type of art. It's perhaps, dare I say, a bit more of a performance art than the kind of artistic art that we would do in the sculpting of our fillings and so forth. And just before, and I suppose underpinning all of this, whatever we do sits in our political landscape, and particularly for our public services, then that political landscape is a key factor. And I've just charted out there for interest, really, my kind of career from when I started at dental school in 1978. when Margaret Thatcher was just about to come into play. I really knew very little about dentistry, and definitely nothing really about public health or dental public health, through the various areas. And you can see it goes from Conservative through a Labour period, and then back to, first of all, there was a slight Lib Dem and Conservative coalition with David Cameron, and then, of course, the Conservative government we've got at the minute. So that's the political background to the story, like the others that I'm about to tell. And the first interesting thing, I suppose, is that I was a pretty late comer to the party in terms of being a dentist. So the little picture up on the top is, for those of you who might recognize it, on the very left, there are some transistors on there. Does anybody remember what a transistor was? It followed valves, and then some integrated circuits. And I was very much, as a youngster, into electronics. I was in the electronics club at school, and I used to love making things and whatever. And the picture on the right was how I put my electronic skills with my mate John to good use, in that most of that stuff there was built by us. And we used to do discos and things. And maybe that's where the kind of presenter, artist, thespian aspect of my character comes into play. And I wasn't really going up the dental path at all until, so in Scotland, I was doing my O grades, etc. And I was at the stage where I was having some orthodontic treatment, and my general practitioner couldn't quite handle it. And he sent me to this building here, which is the dental school in Dundee. And I think it was on the 5th floor was the orthodontic department. And up I went, and I had some orthodontic treatment there. And when I went in, and I suppose there's something mechanical as well about orthodontics, and maybe that was part of it. But I saw these young people kind of going about with the white coats on and doing these things, very practical kind of things. I thought, oh, that might be of interest. And so I applied, and my school was very helpful, allowed me to, I'd done no biology up to that point, allowed me to do biology by popping into other people's classes through a single year to get the necessary biological or biology qualification to get into, along with all the other things, maths and English and science, physics I was really into, to get into dental school. And when I was there then, of course, don't need to rehearse all the things that we normally do in dental school, but there were a few things which came out that perhaps have some influence. First was this document, which was Towards Better Dental Health, a report that recommends new preventive dentistry. And that was in my early days, 1981. There was also this, an article in the Daily Mail that we were furnished with. And I think Dundee has a pretty good kind of public health kind of background, really, in terms of trying to encourage dental public health. And this, our late colleague Aubrey Shyam is quoted in this article. And it was really all about the abuse, if you like, of the fee scale by dentists who were doing lots and lots of fillings because it made them money, which was quite interesting. And then the third thing was this, which was Dick Elderton and his colleague Nigel Nuttall were in the sort of research floor in Dundee Dental School, and they published this article towards the end of my time there, which was about the variation amongst dentists in planning treatment. And it struck me that's odd that, we all get taught the same thing, and yet everybody does everything quite differently, or takes a different approach to the same clinical situation. So I qualified, and I thought, what am I going to do? And I was attracted, I'd been in Dundee all my life, and I was attracted to moving away. And I thought Liverpool would be a good place. And a job came up in the community service, community dental service in Liverpool, community dental officer. And it had with it the attraction of vocational training, as it was then. Vocational training wasn't required in normal general practice. And I thought, oh, well, that's an opportunity to do a bit more development, learning, etc. And this was where I ended up in my first job and my first day of clinical work. And I know we talked a bit about inequalities in our previous previous sessions. And I don't think we need to kind of look very much further than this picture to understand that this was an area with particular inequalities. Norris Green School Dental Clinic, it says on the wall there, and that was the entrance into it. It's not exactly the most inviting place, but the people inside were very inviting in terms of the staff and to initial dental nurses. I'm sure we all know about the importance of that when you're just a youngster. And I also had a very good supervisor in the vocational training scheme, Phil Young, again sadly no longer with us, who was a great mentor in those early days. And so I suppose the message here is about teamwork. We also had Margaret Robinson, was the district dental officer at the time, was very keen on a diverse team, which included using our dental nurses to the full, and also a team of therapists. And so we worked with therapists, and that is just an interesting article. Again, if you don't know, that politics at the time was that therapy really needed closing down because there was going to be too many dentists to deal with the problems of our future. I think, if we're being perfectly honest, politics of it also related to the BDA and the profession in terms of looking to ensure that it wasn't, in their view, diluted by other workers who could perform some of our dental tasks. An interesting kind of perception if we look back on it now. I had lots of opportunities there, and the message about this for my younger colleagues, I guess, is if you're in clinical work at the moment, take every opportunity you get to do slightly varied things. So, for example, there's the young me with our mobile dental unit. Many people, I'm sure, in the audience will have worked on mobile dental units. I got the chance to do it. It exposed me to children with special needs. It exposed me to adults with learning difficulties, and it exposed me to homeless people, all of whom we visited and treated using that kind of approach. And that teaches you so much, helps you to understand not just the clinical dental things, but the background and the things that are the lives that are behind these patients and these people, and I think fits you so much better for trying to understand when or trying to develop strategies and introduce things which will help to improve their lives and services. Technology, of course, I think I still had that little bit of technological kind of bent there, and Phil Young was a great advocate for computers. The early use of Survey Plus was mentioned the other week, and there's me with my ZX81 and my little portable telly, which is all we had really as computers in those days. But I did write a little program to support a survey that we were doing on older people in it wasn't a care home, it was a hospital really with a geriatric ward, as we called them then. But again, there's no excuse now for younger colleagues in terms of technology, utilizing that in whatever way you can to try and push forward with our objectives. The next thing I would encourage you to think about and to do is think about our professional organizations. I got into becoming a representative of my colleagues, first of all, through that vocational training scheme that I mentioned a few minutes ago. They were looking for someone to be on the postgraduate committee that looked after this scheme, a trainee representative, and as always, everyone looks around. I put my hand up, and for me, that was the start of moving out of the surgery and into an arena where I realized actually decisions are made that affect not just one patient, but affect lots of patients and our professional colleagues. So that was a kind of key thing and the start of my broader journey, really. But I would encourage you all to get involved in our professional organizations, because it enables you as a member, of course, to just learn about things. And particularly if you're not a member of BASCO, I'd encourage you to sign up to this organization. But take the chance as well. Don't be afraid. Everybody, all organizations are looking for volunteers to help them run it, whether it's secretaries, treasurers, just committee members, or if a special project is going on, volunteers to help with that. That will give you masses of experience in terms of understanding how organizations function, understanding how committees work, understanding how to put forward your idea and hopefully get it accepted, how to get some support for it before you even put it forward. All of these kinds of things that will help you to achieve your broader aims. And so along with that organizing, this was a time as well when we've just left the EU, but the EU was formed in its current form through the Maastricht Treaty in 1991. And in 1992, my then boss, Margaret Robinson, was the president of the BDA Community Dental Services Group. And as a young member of her staff, along with a couple of others, we were charged with running the event in Liverpool. And so we themed it along the European way, and we invited colleagues from across Europe to come and give talks about various things. And it was a great event. But the point of telling you about it again is, being part of an organization or having the opportunity to organize something gives you a great learning experience. So apart from those kind of informal things in your career, obviously there are more traditional approaches to developing yourself, and postgraduate training is clearly one of them. And in my day, there was no training for dental public health as such. The specialty hadn't been created, but one could do a DDPH and one could do an MSc in dental public health. And so I applied and was fortunately supported, not through the fees, but with my salary through Liverpool Health Authority as it was then. I'm very grateful for that. That enabled me to go to Stanley Gelbier's course in London and do my postgraduate training there. There were some joint sessions there with Aubrey, and Richard Watt was around at the time, who did a previous one of our sessions. And it was a great and very cosmopolitan place to kind of pick up lots of ideas from different people. And my project, interestingly, this thing about the elderly, I kind of followed that through a bit from my very early days and did something using technology again, which was, and it just shows you, you can get your smartphone out now and you can make videos and you can edit them and everything. I tried to look at this difference between professionally defined need and patient defined need. Based roughly on Bradshaw's taxonomy, and took videos of an examination of older people's mouths and got them themselves to look at the videos and say, this is what I think I need. I got their peers who were in a kind of a community old people's kind of exercise class group, really, to look at the videos and say, well, I think may need this, that, or whatever, based on what they saw in the video. And I got some clinical colleagues to look at it and then compared what the different groups thought about what the individual, let's call her May, there were 6 of them in total, male and female, just what they thought the needs of the person were, and then compared it. And that allowed me to use some statistics and all the rest. And fortunately, I got the chance as well to present that, again, through having that link with Stanley at the IADR in Belfast, which was very good. And again, that's something, if you're building your CV, building your kind of experiences, and wanting to be applying for jobs, showing what you've done, etc., all of these things help. The other thing is not to be afraid of exposing yourself to more senior colleagues or opportunities that there are in work for all these kinds of things that there are nowadays around Belbin and various other types of tools to kind of look at your personality, to look at the way you function, development centers to put you through little role plays, etc. I know some people fear them and think, oh no, 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 whatever. But actually, if you can expose yourself to that, you will get so much out of it. And this is actually from 1991, I think it was, when I had been involved in the dental part and just taken over from my Margaret Robinson, who I mentioned, who was the district dental officer. She remained with the health authority, and this was the point at which trusts were created to deliver services, and I became the director of the community dental service. And of course I was offered this training, and you can see the things here at that stage in my career if you've been looking at it. So my strengths were this kind of reflecting style, my kind of openness, my receptiveness to change, and a little bit of good old doggedness and tenacity to try and get things done. But my needs at that point were political awareness, thinking about the bigger picture, understanding this landscape of what was then the purchaser-provider split, which ultimately became commissioning, knowing a bit more about finance, and other agencies. And so the suggestions for my development were exposure to unit-wide issues. So this was the whole community unit, which involved the broader community services and not just dentistry. Links with primary care, which at that point was, and to an extent still is, completely outside community-focused trusts. And then because we were moving into this purchaser-provider kind of arrangement, which, like I say, ultimately became commissioning, a better understanding, or develop some understanding of marketing and the market, because we knew we were going to have to market our services to the health authority, who were the purchaser in those days. So that then led on from that development centre within that same trust to the opportunity to get some wider healthcare experience. We were going into this situation where we were nationally, the policy was to join up the primary care, general practice primary care, not dental, with the community, particularly the community nursing aspect. And this was when GPs were first given funds to buy the services for their local registered population. Now, why I've put the diagram on the right up is because I'm going to come back to that later. That is the kind of primary care network diagram. I know that's an English term for something that is part of the English policy direction. But I think if you look across Scotland, Wales, and other countries, you will find that there is currently a big push on this whole aspect of wider integration of primary care with community services and healthcare in general with local authorities and social services, etc. The recent name change to our, UK government department. So I was given the opportunity to work in this area, famous area of Liverpool in Toxteth, again, a poor and deprived area, very multicultural, with something that was called locality management. And I was the locality manager for that area. And my responsibility was to manage that locality, which had the GPs in it and which had the district nurses, the health visitors, the out-of-hours nurses who did palliative care, etc. And that was a really, sometimes you move into something and it's a kind of, it's relatively straightforward step. It's not a big jump. This was a big jump. Oh, sorry, I've gone too far. This really was a big jump because for the first time, you're out of, or I was, really out of my comfort zone of dentistry. I was in a new world with new people, some very, dogged people with their views about how things should be. Nurses who thought, what's this dentist doing trying to manage us? He doesn't know anything about our work or what we do. So, you have to kind of try and work with that. And I suppose if I was given any advice to anyone moving in that sort of situation, it would be listen, listen, listen. The most important thing is to listen to people and understand where they're coming from. And I think it's not a bad idea in most situations, to be perfectly honest, before launching in with your great idea, is to just sit back and listen a bit to the other people, either in the room or in the area or the trust or whatever it is, and visit them, talk to them, and understand, and try and get some relationship with them that will enable you then to start feeding in where you would like to take this, or where you would like jointly to take it. Because again, very often the secret to success is some joint ownership, or some joint and common ground and common aim and common outcome that you are all hoping to get. So I would advise anyone, if you have the opportunity, stray out of your comfort zone a little bit, and do something, if encouraged to, or given the chance, that is not what you're used to, and just, it will broaden your horizons, and I'm sure make you much better. Even, and I was asked many times, well, not many, but a good few times, to go in the more, and this was a trend back in those days, and more senior colleagues will know of people who did this, which was to move into more generic and general management rather than dentistry. And I said, no, my heart is in dentistry and oral health, and that's where I will stay. But I did have a little time out. And this is just for a little bit of a laugh. Thinking on your feet is something that you could do with while developing, and it came home to me, and many of you will recognise this Tony Jenner here, who was the regional dental officer for the Northwest at that time. I was the leader of the dental services in Liverpool, and there was a campaign on about improving children's dentistry, etc. And this was Granada Tonight on ITV, our local regional station, and we were brought on along with a dental nurse and a patient, who a child, to kind of go through some things in a very serious topic with these two presenters. And immediately prior to our slot on the programme, Peter Kay was being interviewed about his latest kind of programme that he was doing. And he finished, and that was fine. It had been a very jovial kind of thing. The mood changed. We were in a separate part of the studio. We could see the sofa area and all that sort of thing. Separate part of the studio. Off we started on our very serious talk about the problems with children's oral health. And lo and behold, Peter Kay walked right round the back of us and suddenly started jumping about and waving and kind of creating mayhem at the back. Anyway, it was interesting at the time. I was a little bit annoyed, actually, if I'm being honest. But time has passed, and I've got over it now, as they say. However, what subsequently transpired is that at least twice on outtakes on TV and in this DVD, that clip exists. And year on year, I get an email from somebody out of the blue just after Christmas saying, "Oh, I've just seen you on Peter Kay's DVD." So there we are, a little bit of lightheartedness in amongst it. So by this time, I'd done this work in Liverpool. We got to the point where the specialty of dental public health had been created. Specialist registration was available. Obviously, for those who had gone through the training, which of course was in its infancy at that point, but also for those who could demonstrate through their previous experience that they had developed or had experience of the competencies that were in the curriculum and the requirement for registration. So I put together a portfolio with all these kinds of things, many more bits than I've just gone through, which went before the GDC, and I was fortunate enough to be accepted then onto the specialist list. And of course, what that then did was open up the opportunity for consultant roles. So I moved then up to Lancashire and South Cumbria into a consultant role there, which was absolutely great and gave me lots of opportunities. It was based all the way from Preston up to Carlisle, and we chose as a family to live kind of on the southern bottom end of Cumbria, north part of Lancashire, technically just in the Lancashire side, and that was a whole new experience. Again, getting to know a whole new group of people that I hadn't previously worked with. Although there were some, obviously on the lower borders through Bascod and through the epidemiology, which Phil Young had been the coordinator. I had been involved in some of that in Liverpool. And knew then some of the colleagues at the Dental Public Health Resource Centre, as it was called then. Colwyn mentioned that last week, or a fortnight ago. So colleagues there, I obviously knew, but got to know much better. Janet, for example, and that set me off on a whole new set of things, advising what were then the primary care trusts in terms of their dental public health and oral health strategies, but also very much taking, I think at that time, part of what was originally linked to the kind of district dental officer type role that had gone before it, in terms of working with the local dental committees, working with what was formerly the family practitioner committees, and then that looked after the general practice side of things, but then became part of the PCT's role to support them with all of those kinds of very much service-based activities. And having done that for a wee while, I got a call from London, so to speak, asked whether I would be interested in working with NHS employers to support them with a negotiation with the salaried dental service. So I'd had a long career in the CDS. I'd been on the Public Health Committee and the Community Dental Services Committee in the BDA. So it was a bit of poacher turn gamekeeper sort of aspect to this, in terms of whether I would be the professional lead for NHS employers in negotiating with the BDA a new contract for salaried dental service staff. And this again is my main message about all of this. If presented with an opportunity and your personal circumstances don't preclude it for some reason or other, then my advice is take it and give it a go, because that was another interesting learning experience. The first time really that I properly came across civil servants, because as well, although NHS employers was a kind of an offshoot, one of these many kind of quasi official organizations, actually behind the scenes, the Department of Health, and particularly on the financial side, were keen to ensure that whatever deal was done was going to deliver better services for the population. Yes, would provide support for ensuring that there were people, that the salaried dental service was an attractive service in terms of employment and recruitment, which was a bit of an issue, but also that, of course, the from a Treasury point of view, that the money was kept well within expectation. So that was an interesting experience. Again, interestingly, on the other side, leading the salaried dental service negotiation was Janet Clark, who, of course, I knew very well through the Community Dental Services Group, who had chaired the Central Committee for Community Dental Services at the BDA. So, you know, we kind of, there's a lot in the news at the moment, isn't there, about people who do one job and then move on to another one, and then there's all a bit of cronyism and all that sort of stuff. But I think there's an element of the experience that people have and the positions that they find themselves in, that there is, you know, of course, one has to be very careful in terms of then, you know, breaking the previous link with the other organization and things like that. So, for example, when I was doing my BDA work, I completely gave all of that up when I then took a job as a consultant in dental public health, but also part-time as the following Tony Jenner, the Cumbria and Lancashire lead for the Strategic Health Authority, as it was then, which was an outpost of government. So at that point, I gave up all my BDA aspects because I'd effectively jumped to the other side, and this was a similar situation. So I think, you know, take the opportunities, but just be mindful of that, the importance of those kind of regulatory things, and don't put yourself in a difficult position. So that was a good experience. So that then kind of led on through that SHA work, etc., to being linked then to Margaret Seward and to Raman Bedi and various people who were then the CDOs centrally. And it's quite interesting if you just look here, if I read it correctly. Modernising NHS dentistry, implementing the NHS plan. Dame Margaret was around at that point, and she was the one behind pushing all of that, and that was in 2000, followed by Raman's report in 2004, followed by then a framework coming out of the Department of Health in 2005, which then led to the 2006 contract, really, all of which, you know, with a public health perspective, was intended to push on the prevention aspect. And of course, that ultimately led to a lot of disquiet and the Steele Review, which I was very fortunate to be a part of. And that involved, again, this whole idea of team working and a team of civil servants working with us as well. Sadly, again, unfortunately, Jimmy didn't live to see where that has got to so far, and will continue to move on to, I am confident. But in terms of what comes out of that from a learning perspective, I think for me is, first of all, the importance of pathway thinking. So thinking, if you're a clinician, thinking about pathways, and when we think about pathways as well, if you're able to look more broadly, think about what else is out there and what can you bring in to pull the whole thing together, as opposed to starting from scratch and from new. So, for example, Bascott there highlighted under preventive actions for patient and the dental team. This is the pathway we created for the pilots, prototypes, and I hope we'll continue on under Rebecca's kind of guidance between NHS England now and the BDA. Sorry, just go back. Delivering better oral health, an absolutely key part of building in something that everyone wants to happen into a pathway that we then prescribe and say that people should follow if they are delivering NHS dentistry. Similarly with the NICE recall checks. And this is the slide that is not in any of the kind of documentation. It's one of the more original slides, which is why it's a paper copy, which just shows what the thinking was around the things that you now know about. So, for example, lining up as the professional guidance that was already out there, delivering better oral health we know, but the index of orthodontic treatment need, lining up the specialty guidance that was being developed through NHS, the forerunner of NHS England as it subsequently became, and also the GDC guidance that was coming out and our regulatory body guidance. So trying to put everything in in a one place and think about the whole system. So that's my other key message, if you like, is if you can think about the whole system when you're trying to push forward your views. And then there's the broader strategy outside of dentistry that we've talked about. This was Change for Life, a massive, massive kind of movement, really, to try and improve public health. And we locally now, I'm coming back to local, me and Mel Catlou and Mel Smith, we unashamedly pinched or not pinched, but we used a similar theme in terms of colours and look and whatever for our Smile for Life programme. Same sort of idea. And our hope and our ambition was that it would then subsequently get picked up nationally, and we could get Change for Life to pick it up as a programme to associate with it, and it would become a national programme. Unfortunately, in this format, it didn't happen. So not all things are a success, and that's the other thing you have to learn to deal with. Is one might describe it as failure, other might say, well, there's learning comes out of everything, and I agree, there is. It's important that you know, not everything will work all of the time. However, it was well recognised, and we got a poster publication out of it, and it was picked up inside PHE internally. And the other thing I just want to pick up before we're moving towards the close now is this idea of working with partners. So there's obviously individual partners and individual people that you can work with on relatively small projects and things. If you're in a practice, or you're in a community dental service, or you're in a working in a local authority, and it's your local authority plan or project or program that you're trying to do, you work with these individuals, and to an extent, it's there's an element of controlling your own destiny. But if it is bigger than that, then really you have to start to think about working with official partners, if you like, other organizations. And that brings another dimension, because every organization has its own governance, has its own policies, has its own procedures, has its own sign-off. And I know my dental public health national colleagues are on the call tonight. And, there's no greater example than some of the work we were all trying to do to get the decontamination, cross-infection aspects of dentistry and COVID publicly published in terms of guidance through NHS England, Public Health England, government, CMO, everyone. It was really, really, to get the whole sign-off and get stuff out is really, really quite tricky, and it takes a big effort. But what does help is if you understand that these organizations have all these things, and you can work with your colleagues to try and help reduce the bureaucracy burden, if you like, as much as possible. And that includes, in terms of partnership, working not just with the statutory bodies, but with our commercial partners as well. So on this occasion, it happens to be Colgate, but there are other. I worked with Unilever for a while on a toothpaste trial, etc. So it's important that we engage with our commercial partners too, and of course with our educational partners. And this was another example. As the SHA lead, I was responsible for the NHS side and all the development of the infrastructure for the working with the primary care trusts, the development of the infrastructure for the teaching centres that we spread across Cumbria and Lancashire, and for the overall development with UCLAN and HEE as it subsequently became, the development of the, and HEFCE with the development of the UCLAN dental school. Just a final bit of nod here to health protection, because again, it's an important part of public health, and I was really fortunate as well to get early exposure, which helped me in COVID, with the development of the Ebola guidance for dental care teams. At that point, I was working in Sandra's team. She was lead at that point nationally, and I was covering that health protection kind of element of the portfolio. And that exposed me to this whole idea of cells. I'd never heard of cells before. Don't know if anybody else had used in the term of the the way in which we use it now, and we've used it all through COVID, as various cells of people looking after certain elements of the COVID response. The first time I came across the word cell was in health protection. So I was a little bit exposed prior to COVID with the PHE health protection approach. And then if you get the opportunity, yes, I was deputy CEO, and that involved me in all of this development of all of this stuff. But if you get the chance, and I know there are many trainees who have had the chance, but if you just do get the chance in any way through any of the organizations like BASCOD or the professional organizations, BSPD, BOSS, etc., to get involved in the development of any national guidance, then that is also a bit more of an eye-opener and a step towards developing your experience and skill and portfolio as you go on. And I'm sure you've all well familiar, but if you're not familiar, this is where you can find all the kind of latest important guidance, including ultimately the CDO briefings and all that kind of stuff going forward. And the last point I want to make is about legislation. Everything is determined by legislation. And whilst this might be a kind of a boring sort of thing, I would highly recommend that you do a little bit of homework around, doesn't matter so much the historical stuff. The stuff that's still in play, of course, you need to kind of understand that a bit. But to understand the landscape, the playing field, if you like, the rules of the game, you need to know a little bit about the legislation that supports or is behind or kind of determines the boundaries of the project or program that you're working on. And the most important one, and I know this is England, but like I say, it's broader across the rest of the country, the UK and Europe, and definitely in the US, this idea of integration and integrated care going forward. And this is the paragraph from the white paper that's out at the minute, the government has put forward in terms of what they want to do. And there we can see really, really helpfully fluoridation of water by moving the responsibility to make it easier for that to happen. But up above, if you look at the other things, and you go back to Richard's talk around all of the common risk factors, etc., then they're all there. So there's great opportunities in all of this for us. And from a healthcare public health point of view, doesn't matter which level you're working at in terms of the integrated care system structure, there are real opportunities to get involved, even at a neighbourhood level with your, I'm sure the development of the primary care networks or equivalents going forward. So on here, staying well, preventive services, joined up treatment, focus on vulnerable people, links to social care, economic development, local authorities, all that sort of stuff. There are masses of opportunity for everyone to do some type of community dentistry / dental public health going forward. And I return just as an example to Richard's work on the upstream, downstream, and show you this is a real practical example from Blackpool, where I was consultant in dental public health as part of that Lancashire and Cumbria bit. And you can see all the kinds of things that we would normally want to do stacked up practically on effectively Richard's diagram. And I encourage you to use that approach, thinking about where you can make a difference locally. Primary care networks, if you're more of a clinically focused mind, I think there's great opportunities around them going forward. There is a document by National Association of Primary Care that gives some clues to how we can integrate with primary care networks. And as two examples, youngsters at the front end, if you like, the early years environment, the opportunity through the Start and Well programme that exists at the moment, and I'm sure through flexible commissioning or whatever it subsequently ends up being called, there will be opportunities to work with that going forward. And also because the GPs have a requirement through their GP network contract to deliver a care home service, and that specification includes support for dentistry and oral care, an opportunity. And I know what before I left my role centrally, we were working on a flexible commissioning specification to allow practices to be able to support care homes. And my one plea is, if you are getting involved in that, please don't do it in an isolated way as purely the dental practice or the dental practices in an area linked to care homes. It really needs to be linked to the whole primary care approach to the care home through the primary care networks. Now, you might need to convince your commissioners and other people about that, but that I think is important. So there we are. That's a bit of a trot through. Apologies, I am slightly over the things that have happened in my career, but hopefully not just telling you about them, hopefully giving you some idea about why I think the things I've picked are examples of important kind of activities, experiences, or opportunities that if you get the chance and you want to develop your career, be bold and take them. I hope the aims of this evening's event, I hope broadly covered it, and be very happy to take some questions from the group. Thank you very much.
Thank you so much for the presentation you have given us, and we are grateful for the time and effort you took to share your thoughts and experience with us here. And we would like to invite any questions through the chat box. We have already received some questions through the registration. So there are mainly 3 themes which we could find out from the questions we have received so far around contract reforms, government healthcare work interface, and career advice. I'm looking at the chat box. By following this, may I invite Samuel Raj? I can see you have put a question in the chat box. Could you ask this question and we can elaborate on this, Samuel?
Yeah.
Thank you.
Hello, Dr. Eric.
Hello.
Yeah, thanks for the wonderful presentation. So, based on the Steel review, right? So NHS is trying to implement a new model, or it's like trying to involve a blended contract. Has it been implemented, or still is it a prototype?
Okay, so following the Steel review, there was a period, first of all, of piloting, and that pathway that I showed you up there in the 2 diagrams. The first one, the pathway, which basically set out a standardized oral health assessment, followed by a risk rating to understand the patient's risk. And then based on risk, our guidelines, the BASCOD developed along with Public Health England ones, delivering better oral health. The preventive guidelines are all risk-based. So it's important that you undertake a risk assessment for the patient to understand what the risk is. And then through to having done appropriate prevention and encourage the patient to take responsibility for themselves to do their own prevention, through to then whatever treatment is required, etc., and then an appropriate recall. That pathway has been running in those pilots and the prototypes, and continues to run in the prototypes at the moment. And there's around 100 or so of those prototypes across the country. Now, before I left, we just completed the data aspects of the evaluation of that prototyping period. And if you go on to it was about the 2nd or 3rd last slide I think I showed, which had the NHS England website, letters to the profession, you will find a letter there, which from April, which is jointly signed by NHS England and Deputy Chief Exec and CDO, I think it is, which basically says that the BDA and the NHS, because this programme was run by the Department of Health, NHS England has now taken over the reins of moving this forward. And they will be working with the BDA to look at the data from that prototyping period and to work up a further approach in terms of how we will be asking our dental practices to deliver NHS dentistry going forward.
Okay, so it's still it's being tested. It's not implemented yet.
No, it's not implemented yet, and I suspect
Okay.
there will be further iterations of some of the principles, so that we come up with a contract going forward which meet the necessary requirements of both the profession and the NHS, which is why it's been done in partnership.
Yeah, thanks a lot. Thanks a lot.
Aisha, I think you're on mute there.
Yeah.
Oops, pardon. Thank you, Eric. And the next question we have here, what opportunities are there to work in dental public health if you are not DBS trainee or consultant?
Okay, so I hope, I think that's a question which came in before the event. So I hope through what I have said, maybe whoever asked the question, if they're on the call, has some answers from what I've said. But perhaps if I just kind of recap, one of the first things I said at the beginning was that the practice of dental public health or community dentistry, whatever you want to call it, and public health in general, is not the sole purview of trainees in dental public health or consultants in dental public health. In a sense, it's everybody's business. And there's opportunities in lots of ways. If you're simply in, and I don't mean that in any derogatory or unfortunate way, if you're in a practice, there are opportunities to do dental public health things within your practice, or think about the community around you, get in touch with some local voluntary organizations. Many practices I know that obviously we're all families, or people who work in practice who have families and children are at schools. Some parents, as well as being dentists, or their brothers or sisters or whatever, are governors. And, one gets asked to do a dental talk or any of those kinds of things. Now, that's an entry into the local community to make some kind of impact. And the other thing I would say to people is, whilst someone might come with what they think is a very specific ask about what they would like you to do, or that doesn't mean to say that is what you have to do. So if I come back to the negotiation bit, what they've done is tell you what they would like to happen. If you know that that is not evidence-based, or actually it's not going to be very effective, then what you need to try and do in the nicest possible way is work with that person, have a bit of a chat with them and say, well, yeah, absolutely, of course. What you're after here is improving, let's say, the nursery children's oral health, or the older people's oral health, or whatever. Actually, we've got some really good evidence that doing this kind of thing would work, perhaps better than what you're suggesting, and I can help you with that. So I think there's opportunities always round for people to get involved in dental public health type activity. And if you're in an organization and you've got a hierarchy, there's nothing wrong with asking whoever your line manager is, or a more experienced colleague, or a mentor, or whatever. Everyone should have development plans. Put that in your development plans in terms of how you would like to develop, and then people should be able to help you to seek out opportunities.
Thank you. Thanks. Maria, I think you would have something to ask.
Yeah, I have a question, Eric, and it's
Yeah.
one I submitted when I filled out my form, so I'll read it out to you. Have there been times when working for government you found it difficult to promote the evidence-based public health perspective? And what did you do to make your voice heard? I'm presuming now the answer is yes to that first one, but
well, I suppose it's, have you, you can read that question two ways. Have you found it difficult? Yeah. In a sense, personally, no, I haven't found it difficult from the point of view of shirking the responsibility, if you want to put it that way. Yeah. So I haven't found it difficult to say, no, this is what we should be doing. But yes, I have found it difficult in terms of barriers that appear.
yeah.
And that can be disheartening. I think on my little green sheet from when I was, can't remember what age I would have been, but 10 years into being a dentist on that development centre, it said tenacity. Then, you know, going at it is important. Going at it in the same way, again, probably isn't the way to do it, though. So I guess the techniques to be employed then are, okay, so fell at the first hurdle, kind of retreat, have a bit of a think about it. What are the reasons? Try and understand what the barriers actually are, and they may not be the most immediate ones that you first think they are. They may lie behind that, or in hierarchical terms above that, and understanding or trying to diagnose the problem, if you like, is really, really important. And then once you've diagnosed the problem, it's then trying to work out a solution or the next line of attack, for want of a better word. And that may not necessarily be yourself. You may engage some allies. You may actually decide, but depending on what the barrier is, actually, I'm really never going to get anywhere with this. It needs to be somebody else or a different organization or whatever. So I think you have to think your way around the problem or the obstacle. And then, of course, there's always negotiate, which is what I also mentioned. And so you sometimes have to compromise and come to a position where actually it's not your ideal, but it's not below your bottom line that you're not prepared to go below.
Sorry.
Thanks. Thank you. So we have a next one here. Can you describe a day in the life as a dental specialist?
Well, it starts at, well, this is my most recent career. Let's put it this way. I'm being slightly flippant. It starts at 7 o'clock and it finishes at 7 o'clock or 8 o'clock. Wow. No, but seriously, it's a very, very day, and I'm sure there are lots of people on the call who will attest to this. I think perhaps someone with a temperament which is very, I have my day all planned out, and I'm going to do this, and I'm going to do it for 3/4 of an hour, and then I'm going to move on to that, and then I'm going to do the other. Within a very short space of time, that day will go out the window in my experience, because an email will come in from somewhere, something else will happen. It's very difficult, and unless you really, and I know people who do this, and at certain times I have done it also, which is basically to decide you're going to switch off, and if things are happening, they're happening, and you're not going to know about them because you must get something done. But I guess unfortunately, or maybe it isn't unfortunate, but my temperament and mentality is I do like to know what's going on, and I do like to, if something seems to be not going the way that I would kind of be liking it to go, to have my little input into it. And so therefore my days always tended to be a bit more chaotic in terms of that aspect, and hence why I suppose I spent more time than I probably should have doing work. But that said, and I didn't have time to include this in the presentation, but I would have if I could have. We saw some lovely pictures last week or a fortnight ago from Colin about his kind of extracurricular mountaineering activities and so forth. And I know that others all have their various passions. I do too. And I used to have my Wednesday night. I'm also involved in skiing and coaching and so forth. And I absolutely reserved that Wednesday night. Even when I was in London, I would come home on the Wednesday night and go straight there to do my class, etc., because that was such a mental kind of break, because I had to concentrate on something else. And I really do think that's very, very important for all of us, that we have some other outside interests that we can focus on that keeps us mentally stable.
Thank you. Thanks, Eric. Over to you, Maria.
So thanks, everybody. I think that's the end of the questions tonight. And thank you to Eric very much for your presentation. It was interesting and very insightful. Thanks ever so much. And thank you to Aisha, Ross and Ilona for helping hold the session tonight for us. And thank you for all of you taking part and with your questions in advance of the meeting and online in the chat. And thanks for coming along tonight and staying on a little bit longer than we've sort of scheduled for. I'd just like to hand you back to Ross, who's going to say a couple of final words because about what we're going to be doing later on in the autumn. So Ross, handing over to you.
Thank you very much. So hopefully this slide is on the screen. So if you've been to any of the other sessions, you'll know that we're doing this free for everybody at the moment, but we would like to sort of gather a group of people who have a real passion about improving population oral health. And if the masterclass series have appealed to you and you've enjoyed what people have said and they've empowered you to get involved with public health and improving people's oral health, then please consider joining BASCOD. It's we're a friendly bunch, and you know, the membership that we have isn't restricted to those who are dentists or hold a clinical qualification. So the QR code on the screen here will take you through to the membership page. You can have a look at the website and possibly consider becoming a BASCOD member. Also moving forward into the autumn, as we've touched on, these have been such a success. We want to continue doing the masterclass series. We've got 2 confirmed speakers already for that autumn series. We're looking at running it in October 2021. So far, we've already got Professor Cynthia Pine and Dr. Peter Bateman, who both agreed to deliver masterclass sessions. So we're really looking forward to those. Hopefully, we'll have another series of 3. So 1 more speaker to be confirmed. So keep your eyes on the BASCOD social media page for updates on this. We're well aware that there are a number of questions that haven't been answered tonight, and in the other masterclass sessions, we've had some real key themes coming through, and one of the themes that I've noticed is one relating to professional development and careers in dental public health. Now, as Maria's touched on, I'm the early stage career member, and I'm quite keen to try and answer some of those questions that have been put forward. I know that people have asked, how do I get involved in dental public health? And people asking, if you're not a dentist, how do you get involved more in dental public health? And I know Maria is very keen to try and help answer those as well. So we're going to go through those questions. We've got people's emails addresses from when they've signed up. So hopefully we can either record something and put it on the BASCOD YouTube, or we can try and respond to questions directly through email addresses if people have asked those questions, because I know that there was certainly one that maybe Eric might not be able to answer about a master's in dental public health, going into public health training, but that's something that I think I would probably be able to answer. So we'll pick through them. We'll make sure that all the questions that have been answered asked at all the masterclass series are answered. And if anything else comes to mind, don't hesitate to send me an email on the email address that I've been sending out all the correspondence on. So I think that brings the masterclass, first masterclass series to a close. Thank you very much, everybody, for all your hard work. Thank you very much, Maria, Eric, Aisha, and everybody else who's helped out with all the other sessions. And we look forward to seeing you all in the autumn. Thank you.
Good night, everyone.